Hello, and welcome to this special program of Government in Focus, a program brought by the Government of Guyana as we continue to update and inform you about what has been happening and what is happening in the various sectors of government. Today I have a very special guest with me, very important, perhaps the most important portfolio in the context of today's issues. Dr. Frank Anthony is the Minister of Health. Doc, I'd like to welcome you to today's program.
Well, thank you very much, Michael. Thank you for having me on your program, and I hope that at the end of the program, your viewers and listeners would have learned something about what is happening in the Ministry of Health.
I am, of course, your host, Michael Gordon. If we could begin by discussing the general health sector. You would have assumed office just about 2 or 3 days ago, and I'm sure you are there is an ongoing assessment by yourself and team in relation to the current state of play in the health sector. There are very pressing issues today, but if we could begin by discussing perhaps what has your program been like and what have you found so far?
Well, you know, the Ministry of Health is quite a big organization. We have different tiers of the structure, if you like. So we have at the most peripheral levels, we have health posts, we have health centers, then you have district hospitals, regional hospitals, and then we have tertiary facility. So it's widespread, and how the structure was designed was to get the institutions as close to people as possible. And therefore, to run such a system would require a lot of human resources. And of course, you have to make sure that supplies that they need to do the necessary services are there for them. So in terms of the programming, the ministry has several programs, some of which would focus on prevention, others would focus on treatment and care. And these programs have been rolled out with the help of the personnel that we have. We also conduct training, and we do a lot of training so that our human resources can be updated and would be able to provide quality of care. Now, having said that, that's kind of laying the ideal picture of what we would like to see. I have started meeting the staff to do a quick assessment of the areas and the challenges that they have and what we can immediately do to remedy some of these situations. So for example, because the government, the previous government was not operating with a full budget, it seems that a lot of the programs that are normally in place would have been operated suboptimally. For the services that they were providing, most of those services have not been provided for quite some time. And this is very distressing because it would have meant that in some areas and for some of the diseases that we were trying to bring under control, if you didn't do any work for several months, then these things can easily increase. And that's something that's a trend that we are noticing. So I am currently involved in doing that assessment. I had a preliminary meeting with most of the directors in the ministry, and we spoke a little bit about that. But over the next week, I'll spend some more time getting the details, and perhaps at a later time would be able to update you.
Of course, Dr. Anthony, the most important issue now facing your ministry is the reality of fighting the novel COVID-19 disease.
Yeah.
You must have been, I know you would have met with what remained of a task force coming forward from the previous government. This morning you heard President Ali at his inauguration. He referred to a rapid assessment done. That was done as early as Monday.
Yes.
And of course, there is going to be a new structure as it relates to how this government of Guyana, tackles the COVID-19. Just tell me a little more.
Well, COVID-19, as everyone now would be quite aware, it's a pandemic, meaning that almost all the countries of the world are now affected. And because of that, there are some international measures that can be taken, but each country also needs to take on national measures. The previous government, one of the things that it did was to try and set up structures to respond to the pandemic. And they started out by establishing what they call a task force, and that task force had a secretariat. Then they had other components of the response, like having the CDC, having a medical response, and so forth. But when we came in and with the quick assessment that we did, what we found was that the task force was highly political. And if you're managing a pandemic, what you need is political will and leadership, but you have to get the technical people to lead the process, and people who understand infectious disease and infectious disease control, so that you can have the technical things being done. Unfortunately, I think a lot of that was missing, because when you politicize the task force, you don't get the same results as if you had a blend or a mix of technical people with some of the policymakers. And that was one of the big mistakes, I think, that the past administration did. And because of that, maybe the vision of how to deal with some of the problems, they weren't able to successfully do that. In addition, below that task force, you had a secretariat, again, a very extensive structure. But upon reviewing that secretariat, we noticed some of the people who were employed in the secretariat, again, were not people who we need for, say, the fight against this disease, meaning that they have technical know-how and so forth. What we noticed was you had some political operatives. And again, one of the persons that I saw on that organizational structure, he spent 34 days with us at the recount, because he was one of the persons assigned by the APNU-AFC to be sitting in the tabulation room. And so he was there for the last 34 days. Obviously, in the height of COVID, he wasn't doing anything, but he was
COVID-related.
Nothing COVID-related. He was being paid, however, through this mechanism. And you had a number of other persons like that. So when we had said earlier that the task force was highly political, this was what we were referring to, but we did not have specifics. And by now, now we are seeing the structure and who were involved, we can understand why there was this inertia in terms of implementation of the things that needed to be done. And then there was a bit of disjointedness, because while you have a lot of good technical people who were involved in the response, if they're not coordinated, if they're not given direction and leadership, then it becomes very disjointed and dysfunctional. And the response so far has been plagued by some of those things, and that is what we are hoping to correct. So what we have done, and what the President has ordered us to do, was to review what existed and to flatten that structure to make it less bureaucratic and more flexible, so that we can respond quite easily to whatever challenges are emerging with this disease. And so at the top, we have created now, instead of a task force, we have a policy-making body. That policy-making body is chaired by the Prime Minister, and then we have myself, we have Dr. Ramsamy, we have another person from the private sector. Private sector has named Mr. Ramesh Duku as their representative on this body, and we have the international community. The international community is represented by the Pan American Health Organization. We have the representative from the United Nations, the coordinator for the UN here, and we also have a representative, a senior representative from CARICOM. Now, why do we need these people? In terms of the UN representative, as we are all saying, it's a pandemic, and the UN's reach around the world, it's a massive organization, and they have been able to develop lots of best practices from other parts of the world, and we are hoping that we can get some of those and be able to apply it to our context. They are also involved in harnessing resources so that, again, that is going to be essential to aid our national efforts. And there are areas...
Doc, I want us to talk a little more extensively about the way forward. Mm-hmm. But initially, you referenced structure in terms of what was set up, how it was set up, and so on. Mm-hmm. But critical to the success and the effectiveness of any structure also, apart from leadership, which you mentioned mm-hmm. as one of the critical areas where there was a paucity. There's an absence of technical leadership, an absence of leadership that is relevant to the task at hand. Tell me what exists at this point in time in relation to infrastructure as the ministry sought to and seeks to battle COVID-19. What did you meet?
Well, in terms of the infrastructure, one of the key components in this response has to do with testing. Mm-hmm. And the Ministry of Public Health would have what is called the National Reference Lab. Now, the capacity of the National Reference Lab is pretty limited in the kinds of tests it can do and how many tests it can do. And one of the things that, because we recognize that as a constraint, we want to increase that capacity. So as it is now, maximum we can do would have been about 80-something tests, right? And we want to increase that capacity. If you look around the world, you'll see people that got, lots of cases. One of the key things that they've been emphasizing is test, 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 right? Our capacity is quite limited. So having identified that as an issue, we then set about trying to fix that issue. So we have set up a laboratory committee, so to speak, with a lot of technical people. Those technical persons have visited the National Reference Lab to see how we can look at that process and build capacity almost immediately. And in addition to what exists now, we are going to add another set of capacity, so to speak. New biohazard cabinets, increase the amount of PCR machines that they have, and also have more people trained to be able to respond to this, to increase our capacity for testing. So right away, we are going to increase what we are doing at the National Reference Lab. So that's one step. The second step is that if we really want to have many more tests done, the National Reference Lab would not have enough space. And therefore, we are also looking at other sites that you can do the testing, that would have all the laboratory facilities necessary to do this testing. And we have in other ministries, we have such labs. Yesterday, we had a team went in and visit a number of these agencies, look at the space they have, the type of equipment, and so forth. And very shortly, we will be collaborating with those agencies and converting those spaces to have COVID testing being done off-site also from the National Reference Lab. So in a way, in a couple of days, what we're trying to do is to add capacity. One of the major constraints that we have, however, is personnel, because there are only 2 persons in the lab who have the training to be able to do PCR testing. So we have a collaboration right now with the Pan American Health Organization, and as of next week, we want to start training for maybe about 20 to 30 technicians in the area of PCR testing. And once that training is going to be done by virologists out of Washington, D.C. We are going to do that training online. And once that training is finished, they're going to be able to do the practical component of that training in the National Reference Lab. And as soon as that is finished, we'll have a set of technicians, a pool of technicians now that is ready to be deployed to do the testing. So we are working on building this capacity. As it is, I told you, maximum we can probably do is about 80 tests. Our intention is in very short order to be able to go up to about 300 tests per day in the public sector. And I think that would make a big difference once we are able to take it up to that level. In addition to that, we have had some preliminary discussions with the private sector because a number of the private hospitals, they have the equipment to do PCR testing, but it's very costly. The kits that you have to use, it's very costly. And so in a lot of the private sector entities, an average PCR test would cost maybe about $20,000 to $25,000 per test. So next week, I'm going to be meeting with these hospitals, and we'll try to work out a relationship because the government is willing to give them the test kits. And if we give them the test kits, then of course the price would have to come down for the persons who go there for testing. So those are something that we will work out with them. Test kits have been a major problem in this country because when we came in and we were looking at the amount of test kits that were available, in a couple of days we would have run out of test kits totally. And there are some instances during this period where the Ministry of Health did not have test kits. And that is why when you see these things where they were giving results and then they weren't giving results, at times I think the test kits were short, they didn't have any, and the machine was down. So you have things like that. We don't want that to happen. And over the last couple of days, one of the things that we have focused on is the acquisition of test kits. And you would have heard the President mention today that we have gotten from Barbados 15,000 test kits that came in. And that came in just this morning on the flight. And those are now going to be put to use so that we can increase testing. In addition to that, we have been working very actively with the Pan American Health Organization. And by next week, we will get an additional 10,000 test kits from PAHO. And hopefully by the end of the month, we are expecting another 40,000 test kits. So when you think about that, in a very short time, we have been able to mobilize all the kits that we will need and stock them so that, you know, whoever needs a test would be able to get a test. And in that way, once we start expanding the testing capacity and testing more people, we'll get a clearer idea of what is going on with the epidemic in our country. And that's key. In addition to these, what we call PCR test kits, because these tests are used to make the diagnosis. There are other types of tests that are available, and that is if someone has been infected, you know how the body works. Somebody gets an infection, your immune system reacts to that antigen that comes into your system, and they produce, your body now produce what is called an antibody to fight off this infection. So when that antibody is circulating in your blood, you can also test for that antibody. So we have gotten from CIDEMA, that's the Caribbean organization, they have sent 48,000 antibody test kits. These are rapid kits, and if somebody was infected and they develop antibodies and you use this, it would show that they're positive. So we have some 48,000 of these rapid kits. In 15 minutes, you can get a result, so at least it gives you some preliminary indication, right? So there are limited use of these types of testing, and we have been crafting the guidelines so that all our clinicians and persons who want to use this type of testing, they know the limitations of this type of testing. So that's one way in how we're improving the capacity.
You've spoken extensively about structure. You spoke about infrastructure. When we return from this break, I want to ask you some specific questions in relation to physical infrastructure and facilities. We've been speaking with Minister of Health, Dr. Frank Anthony, and we will return after this break with more from the Minister of Health. Welcome back. We're having a discussion with Minister of Health, Dr. Frank Anthony, and currently we're discussing the current state of play with the fight against the COVID-19 pandemic. Dr. Anthony, you spoke at length earlier in this program. You spoke about the structure, the existing structure. You spoke about infrastructure in terms of human resource capacity as well as resources.
Yeah.
I want us to talk a bit now about the physical infrastructure in terms of facilities, what exists. How are we now, and where are we going in terms of what has been prescribed following your rapid assessments?
Well, the ministry has tried to build capacity in the regions. Well, there may be three types of institutions in this pandemic that you need to have. The first one is what you call a quarantine facility. And that is if somebody had come in contact with a person who was tested positive, then you want to have them in quarantine to see whether or not they develop the disease. And if they become positive, then you put them in a different facility that is called an isolation facility. So the first one is quarantine, and that is to check or to keep someone there to see whether or not they develop the disease. Second type is isolation facility, and that is someone who has the disease, right? And you want to monitor them to make sure, one, they don't spread it to other people because they're isolated. And secondly, if they develop severe symptoms, then you can move them from that facility and bring them into the hospital, which is a third type of facility, right? Now, the disease, you would have quite a lot of people who would have very little symptoms. So there are lots of people who might have the disease. They would be positive if you test them, but they have almost no symptoms. These persons, you call them asymptomatic because they don't have any symptoms, right? Then you'll have another set of people who would have some symptoms. It might include some cough, fever, and things like that. Now, by the time these symptoms emerge, whether it's cough or fever, 3 to 4 days prior to that, these persons would have already been infectious, meaning that they can transmit the disease. So if we're waiting until somebody develop a cough to wear a mask, then we would be 3 or 4 days late.
Which brings to the fore a very important point. And I will allow you to continue, but the of contact tracing and the capacity to do so. I want us to have some subsequent discussions on that.
Yeah.
Yes.
So let me just finish this, because I think most people feel that it's only when somebody got a cough then they should wear a mask. That's not so. We need to get people wearing their mask as a part, like if you're going out and you're wearing your shirt, right? You wear your pants to go out, you got to think about this as wearing a mask as well.
I therefore ask the question, is there an intention, a thought at least, to the whole notion of mandatory masking?
That is something that we are actively discussing, because in areas and in places where people have been wearing the mask, the transmission of the disease has been drastically reduced. Again, let's go back to the dynamics of the disease. This disease is transmitted from a person who is infected. If they cough, meaning those droplets would get to the uninfected person and infect them. If you wear a mask, right, then if you're positive and you cough into that mask. So those droplets don't go into the environment. Or if it does, very few of it would go into the environment and it doesn't get very far. Without a mask, some of these droplets can go up to 6 feet. That is why that notion of social distancing, of staying at least 6 feet from somebody, that's why they have that principle in place. But there's also one of the things that has been widely debated is also when you cough, apart from droplets, you also have what is called aerosols. These are smaller airborne particles that can travel further than the droplets, right? And in some cases, they can penetrate and get to you, okay? So that is why it's important that you wear masks, because when they did the simulation of both parties wearing masks, then the chances of infection are drastically reduced. So I have seen a lot of people, you know, want to move around in various environments, but they don't want to wear masks. That's a no-no. Because if we all want to be protected, then we all must take the precautions, right? So if you protect yourself by wearing a mask, and I do the same, then we are all better off, because we are each, you know, with this collective, everybody doing their bit, then the whole community would be safer. But if somebody breaches that rule, then we will have problems. And that is why mask wearing is so important. And I want to use the occasion to appeal to everyone to keep wearing your mask, especially in open public spaces, whether it's indoor or outdoor, we need to have that. In the minibuses, whether you're going on one of these speedboats or, you know, whatever transportation you're using, mask is absolutely important, right? And that's something we can't, you know, we have to keep stressing, because it is so important.
Let's address the elephant in the room, the Ocean View Hospital.
Well, you know my views on that.
It's significantly controversial.
Right.
What is the current state of play? I know you have been written to with a request for payments, and the issues go on. And I would rather suspect, as the days go by, more surrounding this controversial facility
Well,
being released.
well, what we have been told is $1.6 billion have been spent on the rehabilitation of that facility. We know all the legal processes. I'm not aware of what they are. I've seen bits and pieces in the press, but I guess our Attorney General would be able to deal with some of those things when he's written to. But let's take the building. The building itself, from the state that it was in, we know from a couple of Auditor General reports that the Ministry of Health was storing medicines and consumables at that facility. And when the Auditor General went in to do the audit of that facility, they refused basically to go into some of the rooms because of the state of the rooms. And in some of those reports, it's written it was infested with insects and rats and you know, all kinds of stuff. But in addition to that, they had a serious problem of mole infestation. And so when they rehabilitated, I don't know whether they took those things out and, you know, we wouldn't have a problem with mole infestation. So that's something that one needs to think about. The other major problem with that site is the flooding, because we have been told that you have overtopping from the sea, plus you have other issues when rainfall and so forth. And there's a major drainage pump not far from that. So you can have some issues of flooding. And in the past, that was one of the things that plagued that site. Now, barring all of that, when we sent a medical team in to look at the actual facility and to see whether or not it can be used and what is necessary for it to be used, they had, in their minds, they had 197 beds that they were looking at. And of those 197 beds, you have, maybe we can categorize them in three groups. One is ICU beds, right? The second would be high-intensity beds, meaning that you don't meet the requirements for ICU, but you're still critical, so yes, you need this type of bed. And then there's the regular bed, right? For the ICU area, we will need to ensure that there's oxygen and suction and those types of things. And generally, when you're making a hospital, those tubes to bring in oxygen and so forth are normally placed in the wall. This facility was rehabilitated. They had the opportunity of placing those things in the wall because that also reduces transmission and infection spread and so forth. So you need to have these things in the wall. That was not done. So let's assume that we are going to be taking the facility and wanting to use it. We still have to do these works of inserting these piping systems and so forth.
Therefore, some tearing down still to be done.
A lot of renovations would have to be done for that section of the hospital to be used for the purposes that it was intended. In addition to that, they have a section that has to do with dialysis. If you're going to provide dialysis to patients, you would need filtered water. And again, no provision was made for dialysis. The space that you have there, as I described it, I said it's a shell because basically you have maybe walls and floor and a roof, but there's nothing inside. There are no beds, there's no equipment, and you can't have a hospital if you're not going to have the necessary equipment and so forth to treat the patients who are going to be coming there. While in the treatment of COVID patients, earlier when we didn't have a full understanding of the disease, a lot of emphasis was placed on ventilators. We still would have to get ventilators. But now they are moving away from having too much ventilator or putting patients on ventilator at an early stage in the disease, and really only when it becomes extremely severe, then you need to do that. So the way you manage a patient is evolving, but you still need to have the ventilators in place in case they need it. And in terms of the types of ventilators that were bought for the hospital, those that are currently at the place there cannot run continuously for 24 hours. These are ventilators that you use on ambulances, and they are only for short periods, like 2 hours, 3 hours. So if you're traveling with a patient, say from New Amsterdam to Georgetown, they would be able to give that patient, if you have such a piece of equipment on the ambulance, you'll be able to help that patient. But to have someone on a ventilator continuously for 24 hours, those types of machine cannot work. And that's the kind of machine that was bought for the facility, right? So there are lots of things that really, you just have to wonder how such blunders were made. And you can only call them blunders, I don't know, I don't have the vocabulary to describe some of these things that we have been picking up.
Your level of diplomacy has always been admired. But looking ahead, especially as it relates to the task at hand, you have said some. But what are the perhaps key priority areas looking ahead now that we've addressed the Ocean View issue, which has now become
I think for us, the key thing right now is that we are dealing with this COVID pandemic, and we want to make sure that we have all that it takes, whether resources, testing kits, capacity, human resource, whatever it takes, we want to make sure that we have that in place to address the problems that are associated with COVID. And secondly, we know because of COVID, some of the measures that had to be taken, that people are hurting economically, right? And so one aspect of what the president spoke about is that there's the establishment of a social and economic committee that would be looking at how we can bring relief to people who need relief, right? And what set of structures or set of incentives and things that measures that we can put in place so as to bring that relief to people. So that committee is going to start working, and very shortly we will come out with a set of things that we'll be doing to bring relief to people. You see, what we have to do is to have something that is sustainable. There were lots of good people and organizations who, throughout this period, has been helping. They've been giving out hampers and so forth. But we have to move to a sustainable way of dealing with some of these things. And again, as the president announced, we have already mobilized some financial resources, and some of which would be used for these purposes. So, you know, in all, in just a couple of days, I think we have been able to make a fairly accurate assessment of what is happening with the COVID response, but not just to make an assessment, to try to restructure and refashion the response so that we can meet the needs, you know, in terms of what people need out there and how we're going to address them. So that's one set of things. There are many priorities in the Ministry of Health, and maybe on a later date we can talk about some of those. We are currently doing an assessment of the kinds of the needs that we have. One of the things that you might be shocked to know is that over an extended period, the Ministry of Health did not buy medicines and consumables. So a lot of the key and critical programs that we have right now are totally out of medication.
I dare ask the question, what is an extended period? One has perhaps in the health or in the history of ministries and departments of health, it's a concept that is possibly unheard of.
Let us leave it at that. I'm trying to get the exact time. I'll tell you that in a subsequent maybe discussion. But I just want to make sure that I have accurate information. But at this point, I can tell you there are major shortages of medication in a lot of areas. And these are medication that patients need on a monthly basis, but they don't have anything when they go to the health center. This is something that we'll have to correct immediately, because we cannot allow people to not get their medication, right? If you have, let's take an example, somebody who's diabetic, right? And they're on insulin. For several months now, there have been no insulin in this country. And therefore, all those persons who are dependent on insulin would have to purchase their insulin, right? That's a big expense. And so these are things that we have to now work and correct. So I'm now trying to get that assessment done of the medications that we don't have and things like that, and we'll have to move quickly to procure and get these things into the country.
It's very critical that you said that these very important medications are in short supply. In terms of, and I know you spoke some about the human resource capacity, but more specifically, we dealt with that from the COVID perspective. As it relates to the assessments made by you and the human resource capacity in terms of doctors and nurses in the health sector across the 10 administrative regions and, of course, the Georgetown.
That is something that we'll have to do some more assessments on, but I think in terms of doctors, we have quite a good complement of doctors, and that is because in the previous PVP government, we would have trained a number of doctors. I think we had sent about 750 doctors to Cuba.
If I may, Dr. Anthony, especially on that particular point and the shortage of medicines, tell me a bit about what appears to be, and I've had previous discussions on this particular issue, that nationally there is a shortage.
Well, there is a shortage of a number of medicines right now in the system, and what we'll have to do is to get a good idea of what exactly is short, and I've put some teams to work on that to give me a quantification of what is short, the areas. But on a preliminary basis, when we look at it, it looks like there's a lot of diabetic medication that is short, hypertensive, cardiac medication, and these are all our chronic patients, right? Chronic non-communicable diseases. These are patients who would have been at the health center, being treated, being controlled, because they're receiving regular medication. When this is interrupted for prolonged periods, this would then put their health in jeopardy. So this is one of the things that we have to look at very carefully. And you would know, coming back to COVID, that persons who are diabetic and hypertensive and have other comorbidities would be more vulnerable to COVID. Older people would also be more vulnerable. So what you have is a potential time bomb, because if you have patients with comorbidities and they're not getting treatment, it makes them more vulnerable. And at the same time, we have COVID is still with us. So we have to be careful how we are managing these things, and it's I'm trying to look for the right word here, you know, because...
But I'm happy you brought us back to the COVID issue.
Yeah.
Because I really am enthused about whether the Auditor General has been finally able to access very relevant and critical documents to ensure that the project in itself has been transparent.
Well, two things. One,
I'm referring to the Ocean View
yeah, well,
project.
With that specific question that you asked me, there are two things that happened. One, I've put together a medical technical team that went in to look at Ocean View from a medical technical perspective to see what maybe are the things that are outstanding and defective. And that's how they have recommended some of these things that I mentioned to you earlier, in terms of the tubing and piping that are missing, right? So that's from a medical perspective. From a financial and an audit perspective, the Auditor General has gone yesterday, sent a team to Ocean View, and I think they spent the whole day there yesterday trying to comb through and see what is going on. In addition to that, all the documents that the Auditor General has requested, that has been given to him so that they will be able to do a proper report and present that to us so that we then decide on the way forward. So those things are important because if we're spending, and if these sums of money that we're told were spent on the building, then the Guyanese public deserves to know what it was actually spent on. $1.6 billion is a lot of money, and therefore people deserve to know. And the only way we can know that is to have the Auditor General and his team do that type of audit and present those results to us.
Of course, our time is gone, Dr. Anthony, and you have been listening to and looking at Government in Focus, and I'm speaking of health, Dr. Frank Anthony. Doc, I'm truly hopeful that we could do this and many more programs again in the near future as you attempt to, and I know you will be successful at examining all that has been happening in the health sector in an effort to bring optimum health care and health services to the people of Guyana. Dr. Frank Anthony, I thank you for being a part of this program.
Thank you very much for having me.
This has been Government in Focus. I am Michael Gordon. Thanks for being a part of this program.